All right, y'all, Mr. Forney again. We're going to go into part two of our communication and documentation series. We're going to focus more on documentation in this episode. And this will make a lot more sense when you actually get out there working in the electronic medical record and charting the things you do and charting meds and charting interventions and stuff. So be ready that that'll come around, but keep in the back of your mind that same thing we said last time. If you didn't chart it, it didn't happen. That's how this all works. And this is an important form of communication in our field. So we're going to talk about major documentation formats and their components. We're going to talk about the EHR a little bit. We're going to talk about best practices. We're going to think about legal and ethical considerations and correcting documentation errors appropriately. So we have some different options when it comes to documentation formats. We have a PI format, that's problem, intervention, evaluation. That's kind of laying out what you do if you do something. You know, say you have your problem is your patient's in pain, you perform an intervention, you give them medicine, and then you come back and chart what happened. So if they have a complaint, you need to document the complaint, what they did about it, or what you did about it, and if it made any difference. We have a SOAP note. This is a really good way to communicate with other members of the team. You structure it with subjective information and objective information, an assessment, and a plan. There is source-oriented. There is focus charting, where you're doing just the specifics. There is charting by exception. That's most of how we do in the electronic medical record now, where if something is normal, we'll just chart that system is within defined limits, and if something is abnormal, the expectation is we'll chart it. And then there's a problem-oriented medical records out there too. I haven't really worked with that one a whole lot. The PI model, so problem. We're identifying what the issue is. Is it a nursing diagnosis? Is it a patient concern? This can be as simple as patient complained of a headache. Now we're going to document our intervention. Gave a Tylenol, turned the lights down. Then we're going to come back later and see if that intervention actually did anything. So this ties directly to our nursing process, where we do something and then we see if what we did actually worked. SOAP note. These are good for progress notes. So if you're in a place where you're writing your own progress note, this is a good format, but you're also going to be reading a lot of provider notes. So they'll typically set it up this way, where they'll have reported symptoms followed by your objective findings and with the assessment and plan. And that plan ends up being the meat of it for your, like, what are we doing next with this patient? So when you start reading doctor's notes, look for that plan section. It's usually an assessment and plan, and they'll have a bulleted list of, you know, what's the most important issue they're here for and what are we doing about it? What are all the other issues and how are we addressing it? So if somebody got a new medicine and you're not sure what it's for, the first place I would look is in the most recent doctor's note who ordered it to say, oh, you're getting this for hypertension. Then you don't even have to call them. They have it communicated already. Source-oriented medical records. We have a lot of different systems. There are history and physicals. That's the first time the doctor sees somebody. There are progress notes. That's how things change over the course of an admission. This is where my biggest piece of information to stay consistent with the medical plan comes from. It's the most recent doctor's note. There are nursing notes. Our nursing assessment usually gets charted in that exception format, where we just go down and check a bunch of boxes, and that can be useful if you look at it over time. But there may be settings that you have to write an actual note. These are things, particularly when things don't go exactly like you expect. I'll usually go in after some kind of code or rapid response or something and just write a play-by-play of what actually happened so I can get a clear picture. Or if there's just something that needs to be recorded and documented that doesn't fit nicely in the table format that most of our charting is. We have lab reports, which you'll see on there. That's where we can see electrolyte levels and chemistries and all this kind of stuff, testing results. Diagnostic testing, it's really cool. We have access to the actual images. So my favorite one to watch is a barium swallow, where they'll go down. You don't do the barium swallow, but they go down to it and they do, it's a video x-ray that literally watches this radio opaque, so it shows up as dark on x-ray, where the fluid goes down someone's throat. Does it go down the esophagus and into the stomach like it's supposed to? Does it get held up in the trachea? And does it ultimately aspirate into the lungs? Very cool to see, but we can see all that kind of imaging. And then you'll also see consult reports. So these are like if you have your primary as the hospitalist and they need to consult nephrology, we can get keyed in on what nephrology is doing, and the whole rest of the plan for the patient. As nurses, we're at the center of our patient's care, so it's useful to be able to navigate all of these. Focus charting, we have data and an action and a response. So what can be a focus? That can be pain or a change in condition. What did you do about it and how did you respond? Very similar to the PI system, very similar. Then charting by exception. This is most commonly what we do, at least how we do it at Atrium and the other health systems I've worked around here. Caremont does this. It's kind of how Epic works. You go in and chart just what's not normal. So it saves a lot of time, but you got to be careful. You don't want to over chart normals, but there are some things that you want to chart normals. And again, this will make more sense the more we do it, but these are things like, even if your neuro section is technically within defined limits and I can just hit the WDL section, if there's been any question about your mentation, your patient's mentation, if they've been oriented or they've changed throughout the course of their admission, I like to go ahead and include a little more information there. So there are clear standards for your facilities. I'll show you that when we get to clinical too. It actually makes it really easy to see what their minimum charting that Atrium expects you to do is. And then the idea is if there's anything that's abnormal, you find somewhere to chart it. So that'll make more sense when you do it, but know that that's a very common way. It saves us a lot of time, and we just have to be careful with it so that we cover our bases. Problem-oriented, we can build databases, we can have problem identification, make planning, have progress notes. This would be like you have a whole list of problems for a patient. So most of your patients don't have one specific thing. Like a kid may come in and his only issue is a broken arm. But most adults have, they're here for hypertensive crisis, but they also have diabetes and atherosclerosis and X, Y, and Z. So there's a lot of different problems. And it'll talk about what we're doing about each one of those too. Now, fact. These are important details for how you actually want... Excuse me, I got very stuffy. I don't know what the deal is today. I got the filter up here and everything. It's just one of those things. So, factual, we are reporting on what we see, hear, and observe. We are not adding opinion. So I'm not saying the client appears drunk. I'm saying the client's gait is unsteady, breath has a sweet odor to it, pupils are dilated or whatever. Paint enough pictures so that somebody else can get the idea, but don't get your own thoughts and judgments into this. There are other conditions that can look like someone is drunk. And if you start with being drunk, you've just biased the next provider who's going to look, and maybe they'll miss someone who's having diabetic ketoacidosis, which can present very similarly. And you've just slowed down their differential process. You're not the diagnoser here, so don't include your opinions. Client seemed feisty or she's whatever. Just matter of fact. You could state client is anxious, reassurance offered. That's factual. Accurate. You want to be as accurate as you can. If you're measuring a wound, we have so many different little tape measures and things. A lot of our dressings will have an indicator on the side showing you exactly how many centimeters something is. So you want to be as accurate as possible. Versus saying, you measure it with centimeters versus the inaccurate would be, it's a large wound, there's a lot of drainage. How do I measure that? How do I know if that's changed over time? Is it healing? Is it getting better? That kind of thing. You want complete documentation, so you include the who, what, when, where, why, and how, all the pieces that happened. What was the complaint? What'd you do about it? What'd you come back around and do? Was anyone else involved? Did you teach about it? And then timely. This one is very important. And actually, a lot of facilities are getting stricter. They'll get on your case if your charting's more than 60 minutes after the event or something. I know when I came up, I had a couple different preceptors who were great nurses, but they would always put their charting off. There was always another task they had to do. So they were always doing their tasks, and they'd put the charting off, and then they'd be there all night charting. And if you're stuck at 9 p.m. after your shift should have ended at 7 and you're trying to chart an assessment from 8 in the morning, how good is that going to be? What are you going to miss all the details? So the sooner you can chart something, the better. And it's going to be slow at first, I promise, but it will get a lot faster as you get more experience. So don't be intimidated. Now, electronic health records, these are amazing. This is the computer. They make so many things so much easier. Coordination across all the different teams is easy. They don't just have a big chart that's attached to the end of the patient's bed anymore. You could see it, everybody can see it from anywhere in the hospital, and people can actually look at it remotely from the hospital, like the billers and the reimbursement and the insurance people. I don't think work at the hospital. They're maybe out of the airport center, or maybe they're even at home. We can track bigger data, and it's permanent recording. So this, on top of that, it also makes it so much easier to see what everyone else said. You're not trying to translate someone else's bad handwriting, because some of you have very pretty handwriting, but I've also seen from your med grids that some of you have very bad handwriting. So now you don't have to interpret that. Doctors are worst of all. It's very difficult to read their orders, and the electronic health record makes it so much easier to tell what they actually want you to do. So why did we go EHR? Legibility. I just talked about that. It's easy to read. It's hard to mess up. Accessibility. Everybody can get it. They can even get it at the same time. It's not just one document hanging on their bed. The clinical decisions, this can actually come in and chime, like we got a sepsis alerts a lot of the time, where someone might not be showing all the signs that they are getting septic, but they're showing enough different signs that the computer actually recognizes. The temperature is a little elevated over baseline, the pulse has changed a little bit. We need to go ahead and get some culture started and put in some interventions so we can catch this disease process earlier. So the computer can actually help us with that. It also helps with integration, so we don't have to go to a bunch of different places to find radiology reports and treatment records and pharmacy orders. It helps with automatic calculations. You still have to learn your dosage calculation, but now you get the numbers through the computer, so you're just double checking those to make sure you don't do something bad. Then analytics, it lets us step back and take a big picture view and see what we're doing, if it's actually helping or not. Med safety, this is another level of checks for your patient. So when we get into medication administration, you'll see we have our rights we have to do. And part of that now is integrated with the computer. So we scan the barcode, the computer then recognizes the patient. We confirm that the patient matches the barcode and the barcode matches the computer. But now we have another safeguard in place. Then it will not let you scan if you try to scan the wrong patient's meds. And believe me, that's an easy problem to fall into. If you got 6 patients and you can't keep it all straight all the time. So I love any safeguards I can get. Lets us put in evidence-based order sets instead of just willy-nilly what the doctor thinks. Now they can have standard sets to give you. Let's see. Research support. So there's a lot of benefits of the EHR. It can be a little tricky to learn, but it's so much better than paper charting. Don't be intimidated by it. Y'all will be fine. Now, best practices. This goes across the board with computer technology. Don't share your login credentials. You each shouldn't have each other's login credentials. It should just be you logging in. If you are logged into the computer and somebody else charts something under your name, you might as well have done it as far as the legal system says. So on that note, don't share, but also always log off when you leave the computer. This one is an important habit to build. Now, sometimes Atrium's new system will let you just tap your badge to badge in and out, so you only enter your password once or twice a day. Sometimes that works for students. Over the summer, the students were able to do it, but last term I couldn't get the students to get that to work. So your mileage may vary, but always log off, lock the computer so no one else can chart under your information, and no one else can get in and start digging through the record. Be careful how your screens are positioned. This information is sensitive. If you're out in the hallway and the family member comes out and is looking over your shoulder, that's probably not an appropriate way for them to get information. That patient may not want them to have that information anyways. You need to use your strong, unique passwords. When you do go to make your Epic passwords, know that they're going to want to look for uppercase and lowercase and symbols and numbers, and it's going to be a long password. I think it's at least 12 characters, and it might even be up to 16 now. So think about what you want your password to be before the first day of clinical, because you're going to be on the spot when I give you your temporary logins. The first thing it's going to ask you to do is make a new login. I like to tell people this is not my password setup, but this is kind of a trick. I'll do my car make and model. So the make will be all capital, then I'll do a period, and then the model will be all lowercase, and then I'll do a period, and then I'll do the year. So say it's a all uppercase Nissan, period, all lowercase Sentra, period, 1997, whatever. That can be easy to remember because you are going to have to type this thing in a lot, but come prepared and ready to make one of these crazy passwords. Don't leave your workstation unattended. Again, if you leave it unlocked and unattended, anyone can go in and chart anything they want and look up all this information, and now suddenly you've basically committed a HIPAA violation. And just make sure your electronic signature is right. I have had some issues in clinicals where students showed up as somebody completely different, and we couldn't figure out why, but we had to be very mindful about the charting we did. Now, do we make mistakes sometimes? Yeah, absolutely. And we have to correct them right. So I'm going to focus on the electronic documentation corrections here, but no, they're very similar to the paper documentation. You're going to need to follow your facility protocol. The system is going to timestamp everything you do. It's going to save the first thing you charted, so then if you went back an hour later and deleted that and changed it to something else, it's still going to show what you did the first time and the time frame. So if you go in and try and cover something up or add something after the fact, it's going to be a red flag. Like say a patient falls at 10:45 and you hadn't been in there since 8 and you go in after, you go in at 11 and you chart that you rounded on them at 10:15 and they were safe. That's going to be a red flag, and you're going to get caught for that. Now, the original entry will still be viewable. It's a little tricky. It's not quite as straightforward because you don't want the error to be the first thing everybody sees, but they can see it still. So be very mindful when you do this. And then if you make a correction, put a little note on there that says addendum or here's why I changed this, just a little explanation, because this won't usually come up the same day or even the next day. It'll come up 2 months later when you've forgotten all about it. So leave yourself a little help, so if you have to explain yourself later, you can. I'm getting more stuffy as this goes on. I don't know what the deal is. Late documentation, you can clearly label it as a late entry, but it is time-stamped. Identify the specific event, include date and time, sign and date with current date and time too, reference previous notes, ensure no, I don't know. We don't really do paper charts anymore. And the thing about late charting is everything is time stamped. So if you chart something at 7 p.m. that you did at 8 a.m., they can see you're doing that 11 hours later. There are some very important do not use abbreviations. These are safety items. These are things that people have screwed up and patients have gotten seriously hurt from. So we don't use these specific abbreviations anymore. If you are writing out units, like in the case of units of insulin or units of heparin, do not write the U. Write out units, because people can get that confused, or they can accidentally, it could look like an O or something, and instead of 10 units, now somebody gives 100 units. IU, if it's international units, you got to write it out. QD can be confusing, so that should be short for every day. We just write out daily now. Get used to it. There's less confusion that way, because otherwise, QD can look an awful lot like QID, and now instead of once a day, it's 4 times a day, and then you're going to overdose somebody. QOD is another one. You just write it out every other day so it doesn't get confused. We do not ever leave trailing zeros. So what that means, if you're giving 5 milligrams, you're not going to write 5.0 milligrams. You're going to just write 5 milligrams so it doesn't get confused. Now, on the flip side, we always use leading zeros. So if you're doing 0.5 milligrams, you're actually going to write 0.5 milligrams. Now, this is something to note when we get to pharmacology and med-admin and dosage tests. You're not going to get credit if you don't write it out right. So keep that in the back of your mind. It is not 0.5 milligrams, it is 0.5 milligrams, because otherwise we can miss the decimal point. This is an industry standard, just FYI. And then morphine sulfate. There's a handful of other things that we avoid the abbreviations. We just got to spell a lot of this stuff out. Makes patients more safe, makes our communication more clear. So your documentation covers you. It shows what you did. It proves that you did it. If it ever gets looked at later, it backs you up. It can support your investigations. It can support patient grievances. My documentation itself has kept me out of the courtroom. In fact, I had that stroke patient who her mother couldn't accept it, and she was trying to bring action. And risk management came to me 2 months after the fact and said, "No, your charting backs you up. I'm really not worried about what you got going on. You did everything exactly right." And that is exactly where you want to be, I promise. So use objective information. Don't chart your feelings. Don't chart about yourself. You're not saying nurse went to take lunch. You are saying patient observed in bed, safe, bed locked and lowered, patient ate 50% of meal. I don't really, it's not about the nurse. It's about the patient. You're documenting what you actually did for the patient. Usually, if you're unsure, over documentation is going to be better. You just don't want to go crazy with that because that can end up coming back and implicating you too. There's kind of a fine balance. You'll find when you actually start doing it, it is not so bad. So don't stress out, but do think about some of these details. This is a legal record. So can you guys do it? Yeah, you're going to be fine. It's going to be tricky. It's something to get used to. Don't be afraid to practice, especially during clinicals, during nursing school, because that's one more thing when you get out into the real world, you're going to be proficient at, and you'll have one less thing you'll have to deal with, really. So communication and documentation are both inseparable. That documentation is a major way that we communicate in healthcare. Use those fact principles, protect patient privacy. That's a big deal, and that will get you fired. Not many things will get you fired, and this will get you fired. Because if you have a HIPAA infraction, the hospital has to usually pay something like $10,000. It's a whole thing. So use your tools. You guys are going to be fine. If you're ever in doubt, find someone you trust and ask them. Someone that's been there before, been there longer, whatever. And ask. Don't assume you know anything. But you guys are going to do great. All right. I'll see you soon. Stay warm.